All right, we're going to get started. I'd like to introduce Dr. Douglas Zirinsky. He's an associate professor of pediatric gastroenterology at Children's Hospital of Wisconsin. He graduated from Marquette University with a Bachelor of Science in Chemistry and Biochemistry and received his medical degree from the University of Toledo College of Medicine in Toledo, Ohio. He did his residency at Case Western Reserve University Metro Health Hospital in Cleveland, Ohio, and his fellowship in pediatric GI at the University of Maryland Medical Center in Baltimore. And he's certified with the American Board of Pediatrics in General, Pediatrics, and Pediatric Gastroenterology. So let's welcome him. And as I have understood, he will warn us if you may not want to be eating when he shows a picture. So.
All right. Thank you for joining me today. So, talking today about foreign body caustic ingestions, what's come out and when. Some learning objectives: just to be able to identify signs or symptoms that may indicate foreign body ingestion, be able to identify which foreign bodies need urgent referral for endoscopic removal, and to learn the risks associated with specific ingestions. Most important things you're going to learn today are this and a couple slides later on, but always be suspicious. There's going to be plenty of cases that come in and say, we just swallowed something, we need to know where it is, he's having symptoms. Those are the easy ones, but as we were just talking about before, there's always going to be some kids who, I just found this was missing. When did it go missing? I don't know. And sometimes you just need to figure out that they actually have a foreign body and that's causing some chronic symptoms with no history. Second thing, obviously, if you're unsure of what to do or you think a foreign body may need urgent removal, it's always just easier to call us early so that we can give you advice, or if needs be, arrange for transfer. So, some general statistics. Up to 98% of foreign body ingestions are accidental. Most common are coins, followed by toys, jewelry, and other foods. Not that those are food. Many are never detected, and up to 16 to 20% of known ingestions are unwitnessed. Up to 90% of foreign body ingestions will spontaneously pass in up to 7 days. 80% will occur in children, most developmentally normal, and up to 10% are repeat offenders. The most recurrent cases are non-accidental and occur in patients with psychiatric disease or some other reason to have secondary gain from the ingestion. Patients with psychiatric disease and developmental delay are also at higher risk of sharp object ingestion. It was also just an article that came out in the last week that said that the number of foreign body ingestions had dramatically skyrocketed in the last couple of decades. From 1995, it represented about 22,000 annually and about 10 per 10,000 kids in the emergency department, and it's skyrocketed up to about 18 per 10,000 in the most recent years. So good to know as much as possible about these. About 10 to 20% of foreign bodies will need endoscopic removal, and up to 1% may need surgical removal. So by and large, it's fairly safe for most foreign bodies. It is most important to identify those that pose risk of complications or of being retained. The risk for perforation in general is low, but is increased with button batteries, magnets, or sharp objects, which by themselves represent up to 30% of perforations. Sharp and long objects together account for up to 35% of perforations from foreign bodies, as most of the long objects are also the sharp ones. Symptoms may range from mild to severe. The mild end of things being completely asymptomatic. As we said, you can sometimes discover these completely coincidentally. Chest discomfort, odynophagia, dysphagia, and swallowing difficulties, and abdominal pain. On the more severe end of things, you can have vomiting, retching, stridor and wheezing from tracheal compression, feed refusal, drooling, or even vomiting blood if it's on the more extreme end of things. So obviously those ones we want to know about a bit sooner than the other ones. Wheezing and fever should also raise concern for a respiratory tract location of the foreign body, as this can be kind of confusing. So always make sure when you're getting your x-rays, if you have a radiopaque foreign body, that you're getting laterals as well as AP films. You also should be alert that you may encounter ingestions that are not recent to the acute ingestion or presentation. As I said, they can sometimes be in there longer. So where do they usually get stuck? The most common sites of impaction are the upper esophageal sphincter. 60-70% of esophageal foreign bodies are stuck in the upper esophageal sphincter. and therefore usually fall in the realm of ENT removals. But also it's very common to have them get stuck at the aortic arch and the lower esophageal sphincter, and then in the rest of the GI tract, the pylorus and the IC valve are very common. It may also present at any site of pathologic narrowing, dysmotility, or prior surgery, because sites of prior surgery may be both narrowed and dysmotile. Long objects are also prone to get stuck in the duodenum, at the ligamental trites, end of the rectum, as these are retroperitoneal structures, and therefore are not mobile enough to let these pass on their own. Just think if you've ever had something trying to get your hand behind a register or under a grate, it's not very easy to do that. So perforations are also most likely to occur in the duodenal loop or the ileocecal valve due to the fixed, non-flexible retroperitoneal locations. So when you have a kid with suspected foreign body ingestion, history is the most important thing to start with. What do they eat? When do they eat it? How much or how many of them do they take? What symptoms are they having, if any? Do they have them at the time of ingestion? Are they having them now? And of course, a physical examination to figure out, are they doing okay? Do they have any concern for complications? You should assess for the location and suspected complications, usually with radiology. Asymptomatic foreign body that is radiolucent, such as glass, wood, or plastics, require endoscopic assessment. Again, that's if they're symptomatic. If a foreign body is radiolucent and asymptomatic, a consultation with radiology to see whether a little bit of contrast may be helpful could be useful if you trust that radiologist. When the size and the shape of the ingested item is unclear, it is often also very helpful if the parent brings along an extra or a spare of whatever was ingested. So if they had one earring, bring in another earring. If they think that they ate a battery, bring in another one of those batteries, if they have it on hand. This should not be something that delays premature diagnosis. But it's also very helpful when they come to us for a removal in the GI suite and we have one of the objects available. That way we can play around our toys, figure out what the easiest and quickest way to get it out will be. And they can even have their significant other, if they happen to be at home, or run get it in the meantime, because usually it takes a while to set up the OR anyway. If the symptoms resolve during this workup process, do consider reassessing where the foreign object is as it may have progressed, and something that we thought may need to be taken out may have advanced beyond where we can take it out and just might need monitoring or might need some other therapy. So these two slides are the next most important in this presentation and the things that you're most likely to want to know. Objects that are most likely to pass on their own are those objects that are blunt, things that are non-caustic, objects that are less than 2 to 2.5 centimeters in diameter, so think in your second shortest dimension, and less than 5 centimeters in your greatest dimension, or in the under 4-year-old brow, less than 3 centimeters. Any object that is beyond the esophagus is generally much safer and more likely to pass, because as we said, 3 of those choke points are in the esophagus, or 4 even. And then in kids older than 4 years old. Urgent removal is required for any symptomatic foreign body. Any symptomatic foreign body needs to be removed or needs to be closely observed for possible surgical removal. Anything that's sharp needs to come out. Anything that's longer than 5 centimeters or wider than 2.5 centimeters all need to come out. And then multiple or unknown number of magnet ingestions, magnets plus any other metal object, button batteries in the esophagus, any signs of airway compromise or esophageal obstruction, failure to pass the esophagus in 24 hours or unknown ingestion time, and then any superabsorbent materials. Unfortunately, this is something that never really left the market. Unfortunately, we don't see a lot of them, but these are pretty much everywhere. You can find them very easily online, and frankly, something like that looks quite delicious. I'm not sure I wouldn't want it. But unfortunately, these can hold up to 100 to 200 times their weight and volume in water, and they're superabsorbent polymers, and when they foam up, they can be quite difficult to take apart, and if they start foaming up before we can get to them, they may need surgical removals, and they may obstruct both the stomach and the esophagus. Most routine foreign bodies, we're talking about the esophageal foreign bodies right now in general. Most routine foreign bodies are acute, however, chronic retention is possible. So look for signs and symptoms that include decreased PO or feed refusal, aspiration, weight loss, vomiting, and fistula stricture development. Sharp objects are always an emergency in the esophagus and require immediate removal. It's also important to have surgical backup at the time, so when you're notifying GI, notify surgery as well, because every once in a while, most of them will come out easy, but if the sharp end is leading, that's a big no-no for an endoscopic removal alone. And there's always the risk that it gets embedded in the side. It looks fine when you're going on the endoscopy, and there have been cases where it turns out that the sharp end was embedded in the side. You remove it, and they've already perforated, and you just let them exsanguinate. So having surgery on hand is very important in these cases. Sharp end trailing is less risk for perforation. Signs of perforation that you should be looking for on your exam, especially if you have foreign body in the esophagus, are neck swelling, crepitus, especially along the clavicles, pneumomediastinum on imaging, and any signs of respiratory distress. A physical exam should therefore include the neck, chest, and oral pharynx to help assess for complications and emergent conditions, as well as any oropharyngeal trauma that they sustained while swallowing. Any AP and lateral films of the neck, chest, and abdomen to localize and define the object if possible. I say that you should also be having the whole abdomen, because you never know when they swallow more than one thing. Children are not always that clear about what they swallow. Radiology may miss radiolucent foreign bodies, and sometimes minimal amounts of contrast may be used if a radiolucent object is suspected in the esophagus, again, as long as there's no signs of obstruction of the esophagus, because that's going to be a risk for them vomiting and aspirating. Also consider that if they're going to need a rather urgent removal because they're symptomatic, do not do this because it may cloud our vision during the endoscopy and make it more difficult to remove the object. CT reconstruction is also an option sometimes, so I would consult with your radiologist to see if that's an option for you, and if you're concerned that there is a radiolucent foreign body in the esophagus. Asymptomatic low-risk objects may be observed for 12 to 24 hours for spontaneous passage from the esophagus prior to needing a more urgent removal. Glucagon has been well studied in the past, and the jury continues to be out on it, especially if you're in somewhere further away. There's going to be a delayed transfer. It may be something that's worth trying, but the efficacy itself is low, but the side effects are also low. So if it's going to be a while, you may try it if you'd like, but don't let it delay transfer. Let's move on to some specific foreign bodies for a moment. Goins, the most common ingestion. So, as many of you probably know, the most typical area for it to get stuck is in the upper esophagus, and when you see it, it tends to orient in such that on an AP film you will see it in a circular fashion, and then on lateral films it will come, you will see it as more of a sliver. Whereas if it's in the trachea, we often see the reverse. So it's important to be aware of the size of the coins, and radiology may give us some indication of the rough size, but I've had them be off by even 5 to 10 millimeters on it, and that can make a big difference for these kids on whether it's going to pass the pylorus or not. So in general, we're probably going to have easy passage of dimes and pennies in most people, and then quarters and dollar coins, as you can see that they're closer to that 2 to 2.5 centimeter cutoff, are less likely to pass it in general. Of course, we have plenty of kids that these get past the pylorus anyway, so it's not hard to pass roll. It's also important to be aware of the fact that there may be non-standard coins, old, rare coins, or foreign coins. I had one family that came in to me just earlier this year, and it was an Indian family, and they swore to me that what their kid ingestion was some Indian coin. So I was Googling all the Indian coins and trying to figure out what this might be. Turned out to be quarter. So parents are not always accurate in their assessments either. Coins can remain in stomach for up to 4 weeks without need for acute intervention, after which non-urgent removal is recommended, as it's simply unlikely to pass after that. It takes a while for them to do any real damage. X-rays should be obtained every 1 to 2 weeks until it passes. Motivated parents can be encouraged to strain the stools to look for passage, as it helps them to stop having any further X-rays if you can confirm that it passes. Symptoms of gastric outlet obstruction, pain, or peritonitis require more urgent removal. Rarely we may retain a stomach in the body for longer and find that it can actually epithelialize, so start moving into the gastric wall. But usually these are just superficial above the just in the mucosal layer, and they're usually still safe for endoscopic removal without any increased risk of bleeding or perforation. Multiple coins are an exception, and you should always try to remove them because these are going to be at higher risk of longer retention and possible obstruction. And this kid looks like he does. $2. Oh, magnet injections. Hopefully we're not seeing too many of these, but back in the early 2000s, we had successfully removed these toys, these rare earth magnets from the market, and unfortunately they are now back on the market due to lawsuits from the industry, and they are very plentiful. If a single magnet is ingestion, you can just follow the rules for coins and make sure it's not causing any damage. However, make sure you should still follow the serial KRBs and make sure that they are not wearing any tight-fitting metal clothing or belt buckles or what have you, as that would put them at increased risk of perforation. Of course, if multiple magnets or a magnet plus another metal object that might be metallic or magnetic is ingested, immediate retrieval is indicated due to the risk of small bowel entrapment and perforation. If the magnets are beyond the reach of the endoscope, then patients should be admitted until either they have passed the magnets or surgery is needed. I did have a case last year where a kid had swallowed a stack of magnets, little circular ones that you have in the fridge. Those are not nearly as strong, but because of the risk, we did follow him and try and flush things through. Got stuck at the ileocecal valve, did a colon, fortunately he was asymptomatic, we went and did a colonoscopy, finally got into the ileocecal valve, and I couldn't find it. Had to get the fluoro in, and it turns out that as soon as I popped into the valve, it stuck onto my endoscope. We were able to drag it out that way. That was very frustrating. So, a couple graphic pictures coming up in the next two sections, so if you have gentle stomachs, I apologize in advance. But these are what you would see if you just Google them. So obviously they're very strong, they maintain that shape without any connections in between them. And they're actually quite fun to play with. They often sell them at science stores, like at museums and such as well. Oftentimes if you have a bunch of magnets ingested, it's also important to figure out were they ingested all together or did they sit there and take them one at a time? Because if they're all together like this, there's a good chance that they may spontaneously pass and move through on their own accord. However, if they had this, even this is not a guarantee that it's all going to pass on its own, so you still want to make sure that everything is passed. Even if you get some of the magnets out, make sure that you get an x-ray to make sure all the magnets are out. And this is what it looks like when you have a perforation. This is actually only 2 magnets, and you can see it went through multiple layers of bowel with its damage. Wow. That kid lost a lot of small intestinal function. So food boluses and mesoworms. Esophageal food boluses. Meats are the most common esophageal food impaction, and historically meat tenderizer has been considered when no one's been impacted. However, please do not use this. Our esophagus is also made out of meat and you will do damage. Breads are also very common. I've had a kid that had pizza crust, pizza crust ingested. Oh, we're good. So any esophageal food bolus that gets impacted in the esophagus should be considered high risk for eosinophilic esophagitis, and accordingly getting samples. So one of the unfortunate things is that out in the further communities, we'll have people who are with some of our adult GI friends. We will have esophagi that they took care of the impaction, but we didn't have any biopsies at the time, and so we need to go back in and get additional biopsies to look for it. Now we're not asking that the actual site of the impaction be biopsied, especially if it's irritated, but if there's anyone in this room that's an adult GI, we would appreciate biopsies to the rest of the esophagus at that time. That would be wonderful, and so that we can potentially avoid a second endoscopy. So other causes that may predispose you to food bolus impaction are prior caustic ingestions, surgeries, slings, wounds, and strictures, and a history of tracheoesophageal fistulas, as these of course are all surgically repaired. Even the ones that have had just clipping in the site are going to be at increased risk of narrowing at that site and retention of foreign bodies and food impactions. Any food impaction, just like any other foreign body, may remain in the esophagus 12 to 24 hours prior to removal, as long as it's asymptomatic and there's no signs of obstruction. Mesoworms. So these are tightly packed collections of partially digested or undigested materials. May consist of non-food items, but is generally but many of them are food as well. Food bezoars may occur in patients with dysmotility or gastroparesis, and often are poorly visualized in imaging studies and only give signs of gastrointestinal obstruction. So these are people who have some other reason to have bezoar ingestion, and then they're having issues with food intolerance, vomiting, nausea, issues like that, early satiety. They can often be seen incidentally on contrast studies as a filling defect. I had one patient during fellowship who had Creutzfeldt syndrome, and this kid is severely developmentally delayed, of course, but he was a very friendly young man, and anything that he could reach would go immediately towards his mouth. So quickly learned not to let him have any medical gauze, sponges, anything like that, as those get to be very hard to take out. Bezoars may be large and may possibly need surgical resection and removal due to the size and inability to remove them endoscopically, particularly because these will go in small and accumulate over time and become much larger to the point that they cannot be removed unless it's piecemeal. And for some things like large amounts of meat or hair, then that means trying to cauterize through it or cut through it, which is not that safe. It can be very time consuming and a very long very prolonged exposure to anesthesia. So, a couple slides coming up that you may not want to see. Trichobezoar, which is hair accumulation, may also cause intestinal obstruction due to Rapunzel syndrome, which is where you have a hair bezoar that was originally in the stomach, starts to snake into the small intestine, and can act as a focus for intussusceptions. More common in developmentally delayed and populations, and those with psychiatric disease. Trichotillomania, if you have any kids with that, they're going to be at high risk for this syndrome. Body packing. Hopefully we're not seeing a lot of this up here in the Midwest, but this is ingested drug packets used for drug trafficking, and it's a huge risk to the patient because if this happens to rupture, depending on what drug is inside, they may die very quickly, especially if it's something like cocaine. So it's very important not to do an endoscopy. There's no rule for endoscopic intervention because of the risk of perforating it. And they require whole bowel body intervention as well as a surgical team on standby to make sure that they don't rupture. Phytobezoars. So these are made of plant or fruit matter. The most common across all age group. It's more common across all age groups, meaning that there's no distribution. And the most common association is with persimmons. And I'm not talking just eating 1 or 2 persimmons. These are the people that are eating them all the time. You have them locally, so we're probably not a huge risk. This is a trichobezoar. And as you can see, this person eating enough hair to mimic the entire shape of the stomach and narc loop. And then on the right, you can see how this can act as a focus of intussusception. It drags the line into the stomach with in a small bowel with increased friction further into it, creating that telescoping that causes the intussusception. This is your friendly neighborhood persimmon and the concretions that it can cause. Fortunately, these are fairly easy once we get inside to break up and then remove piecemeal. And then probably the most common one that we're going to see in practice is lactobezoars. So these are milk bezoars. They typically occur in infants and may present with abdominal pain, increased vomiting, gastric residuals if they happen to be in the NICU, and poor feeding or feeding intolerance. It's most often noted incidentally in contrast studies, and the treatment is usually IV fluids and a warm gastric lavage to dissolve it. Be particularly alert for premature infants that have this, as well as kids that are in the NICU. It is also a little bit higher risk actually in breastfed babies versus formula-fed babies, but it can happen in both. And this is what a lactobezoar would look like on a contrast study. You can see here that we have a radiolucency, a couple of them, and the contrast covers the outline around it, so it's actually very easy to see here. You can also technically detect them on ultrasound, but it's highly dependent on your technician. So, button battery ingestions. So this is your typical button battery. The way you differentiate this from your average coin is because you're going to see this double ring or double halo sign where it has 2 concentric circles there. If you happen to see it on its edge, because you can see that there's a step off here, you may see a step off as if 2 coins were stacked against each other. So it's highest risk in the esophagus. Also, We already talked about the differentiation. This causes corrosive damage from the battery acid. It can cause pressure necrosis, but that's usually a more long-term problem. And it causes, most important of all, electrical damage, hydrolysis of the tissue around it from a closed-loop circuit. And that's why button batteries are of particular risk, because they're small and the positive and negative end are fairly close to each other. It only takes a very small amount of compression with the tissue to close that loop and get the electricity flowing. Tissue injury can occur in less than 2 hours, so these are very emergent. In fact, the AAP is its own advocacy group formed around just this. If you happen to know any button battery ingestions, you are encouraged to call that number to report it, whether they are symptomatic and have problems afterwards or not. This is a button battery ingestion from a little bit further up the esophagus. You can see that's already causing corrosion of the tissue. It's basically cooking it as well. And this is what it looks like after they've lavaged and gotten some of the debris off. All you need to do is Google hot dog and button battery, and you will be able to see a video in time lapse of just putting a button battery between two halves of a hot dog and seeing just how quickly it cooks. It is not an entertaining video, but quite educational. So button batteries can lead to tracheoesophageal fistulas, arterial or aortic perforations, esophageal or mediastinal perforation, and vocal cord paralysis by nerve damage. Also pneumothorax, depending on where it perforates into. It is one of the leading cause of fatalities from ingestions, especially when not removed promptly. The highest risk is in kids less than 4 years old because they are smaller, greater than 2 centimeters, again because of the problem with stretching of the esophagus and closing that loop, and with lithium batteries as they have higher charges. In general, after esophageal button battery removal, children are still going to need to be observed in the hospital for up to 24 hours because of the risk of secondary necrosis and perforation that may manifest later on. Once it's in the stomach, button batteries may be at high risk of stomach irritation, but in general, the risk for perforation is significantly decreased. I said before that part of the concern is the causticness of the button batteries, but modern batteries in general are better at sealing off and having less button battery leaks, but older batteries or batteries from an older generation are going to be at high risk for that. Batteries that persist in the stomach after 72 hours should be removed regardless because they're going to be at increased risk of these problems, as well as perforation in the stomach from battery acid. Batteries in the small intestine and colon are low risk and should generally pass without intervention, but like any other foreign object that's very opaque, follow them through and make sure they come out. Piloesophagitis. This one is not uncommon, and I'm sure many of you have actually seen it once or twice. Pills that lodge in the esophagus can cause pressure ulcerations or injury with medication disintegration. Some may even be caustic. And the result is usually ulceration and scarring. Most often the ulceration is fairly superficial. Risk for piloesophagitis increases with large pill size, decreased salivation, so kids that might be on Robenal, or glycopyrrolate, I apologize, or insufficient fluid intake. Those people that take their pills while lying down, or abnormal anatomy or dysmotility, just like any other foreign body. It's also more common in EOE. Perforations in themselves are uncommon. Generally, the medications will start to dissolve before. Medications that often cause piloesophagitis, some that include acid damage are tetracycline, or doxycycline, and ferrous sulfate, or alkaline ingestions with phenytoin, and then you can also get caustic damage from alendronate, KCl, NSAIDs, and quinines, along with some pressure damage from them. The symptoms are usually chest pain, dysphagia, odynophagia, and vomiting. It's often common that the pill may have already passed and they still have some of these symptoms, though less likely the vomiting. Treatment usually includes an increase in fluids, changing the med if possible, and afterwards you may give them a short course of PPI and some Carafate for healing purposes, as well as some counseling to make sure that if they're going to remain on the same medication, they take it in the proper position, so upright, make sure they have plenty of fluids along with it. If symptoms are persistent or severe, endoscopy is usually enough to confirm discrete ulceration consistent with the history. Very rarely do we actually find the pill intact when we get down there, but if in the event that we do, we may consider just trying to break it up or push it down into the stomach. Children with anxiety may be at higher risk of globus hystericus. I should have also mentioned this with the food impactions. Anytime you have one food impaction or an episode of esophagitis, I've had numerous kids come back to me and say, complaining of problems swallowing other things when they had no problems before this. And generally the way to treat that is with cognitive behavioral therapy and counseling for their anxiety at baseline. Sometimes we're necessity to do the endoscopy to prove that there's no other pathology there as well. Some generalities for the small intestine. In general, surgical removal of objects if they fail to progress for more than 1 week from a single location. Emergent surgical removal should be considered if they are symptomatic, and in fun batteries, surgical removal if they fail to progress. Larger batteries and coins, same as the general rules. Again, the larger batteries, such as your AA and AAAs, are much less likely to cause any significant damage, and their risk is more of non-progression. Large objects and sharp objects, if they are in the endoscopic reach, meaning even if they are in the proximal small bowel, we may still try and get them because of the increased risk for them. There is an axiom that says that sharp objects, if they are in the small intestine, usually the sharp edge trails, which is beneficial for us, but we always have to be aware that we can't really orient these things on the x-rays very well. Food impactions, by the time it's in small bowel, no problem. Narcotic packets, again, hopefully we're not encountering these, but do not touch. And multiple magnets, if they're within reach, we're going to remove them as well. So some rectal foreign bodies. Not every foreign body is ingested. So these are more associated with adults than children. Almost always intentional due to either sexual acts, drug trafficking, or attention-seeking behaviors. And we did have one kid who managed to shove up, I believe it was 12 colored pencils, full length, up his rectum to try and get out of a psychiatric center. We had to remove them endoscopically due to the large number of them, and he went right back to the center. But he got his day trip, and he was happy with that. Retained foreign bodies may be a risk for rectal perforation and require removal, possibly under anesthesia. Hopefully you're not seeing anything like scrubs where people are shoving light bulbs up their bottoms. Caustic ingestions in my last section. So we all have heard about Tide Pods. They do look quite delicious, but please do not. And of course, these are caustic ingestion that are causing a lot of problems nowadays. The number is not high, but of course they're very prominent, and the packaging makes it very attractive to particularly young children. So it's most common from years 1 to 3 because they are finally mobile, they can reach anything in the bottom couple of shelves, and they do not know the difference between real food or not. But it can also occur in teens as a method of self-harm. Incidence has been reduced in the last couple of decades by laws that require caustic products to have protective opening mechanisms. So think like your medications, they have special locks on top. And they also require that there be less than 10% active ingredient. Gone are the days when you can buy 70% bleach solutions. These laws are usually not found in third world countries where ingestions remain high and often are more of a problem. Many ingestions may still occur because of open containers or products that have been transferred to other containers. Symptoms range from drooling, respiratory symptoms, PO refusal, dysphagia, dinophagia, abdominal pain, vomiting, and of course in the most severe cases, vomiting blood. Oropharyngeal exam correlates poorly with damage to other parts of the GI tract. So if they go in and they have a lot of burns in the mouth, don't necessarily assume that they have a lot of esophageal problems, and vice versa. If you look at their mouth and it looks completely fine, doesn't mean they didn't drink enough to cause them some damage. Alkaline ingestions are in general more common because they taste less harsh and they're more pervasive in our cleaning supplies that you would find in the household. So think your Tide Pods, and you can have liquefactive necrosis of the esophagus and stomach due to your alkaline ingestion. So if you're going to have an ingestion, I would much rather it be acidic, but they tend to be less common. Acidic ingestions may cause coagulative necrosis and eschar formation, and they are also a risk for pylorospasm and antral pooling in the stomach. So even though these structures are generally more resistant to acid because we make some fairly strong acid in our stomachs, it is also that much acid is going to cause some pylorospasm and additional problems and irritation over time. Other chemical agents such as iron, pine oil cleaners, NSAIDs, and oxidizing agents such as your hydrogen peroxide bleach can cause ulcerations, but stricturing is unusual. Stomach injury is more common than esophageal injury simply because of the short trim, short distance, short dwell time, small dwell time, and the resistance of the esophagus to acids and coagulant and necrosis. Stomach is also at risk from both strong acids and alkaline substances, and severity of damage depends on the time and pH of the exposure. So it can be anywhere from just some mild inflammation, but on the severe end you can get fibrosis, ulceration, hemorrhage, necrosis, and perforation. Strong caustic substances are also a risk for antropyloric stricturing. Think 4 to 6 weeks after the fact, so if you know that they've had something like that, an ingestion, and they come to you later with nausea, vomiting, poor feeding tolerance, signs of poor gastric emptying, this is a risk and you should be referring them back to GI so you can take a look. So what to do when you have a kid with a caustic ingestion? First, as with any kid in the emergency room, assess and stabilize your patient, examine for respiratory involvement, and obtain a chest x-ray and a KUB to help assess for any signs of aspiration or perforation. Identify the ingested substance if witnessed. If it's not been witnessed, you can often have who's ever at home go and check and see if any of the bottles have been opened or if there's something that seems a lot lighter than it used to be. If also possible, try and figure out how much has been ingested, the time since ingestion, and symptoms both then and now to try and figure out their prognosis. Once you have them stabilized, contact poison control, as many mild ingestions require only some observation in the emergency department, and they will help you to know the caustic nature and the pH of the substance that they ingested for their prognosis and need for GI contact. If they are symptomatic, please make them NPO, IV fluids, IV PPI for gastric protection, and contact GI if it's been indicated. Of course, if you have more severe, you may want something like hematemesis, you may want to get surgery involved earlier than later as well. Do not induce emesis, but also do not do any gastric lavage. This is a risk for aspiration, especially since they have pylorospasm, as well as exposing more surfaces to the substance. Severe and symptomatic caustic ingestions without concern for perforation or respiratory symptoms, I should add, should undergo an EGD within 24 to 72 hours to assess the extent of damage and help assess for prognosis. This way we can help determine if they're going to be at an increased risk for esophageal stricture later or delayed perforations. All right, some takeaways. The two same slides. So the objects that are most likely to pass are those that are blunt, non-caustic, less than 2 and 2.5 centimeters in diameter, greater or less than 5 centimeters in their longest length, so think pencils and things like that. Things that are beyond the esophagus, and children that are greater than 4 years old. Urgent removal required for any symptomatic foreign object or food action source. Sharp, long, greater than 5 centimeters, wide, greater than 2.5 centimeters, multiple or unknown number of foreign magnets, button battery in the esophagus, airway compromise or esophageal obstruction, and failure to pass the esophagus in 24 hours or an unknown time of ingestion. Some quick references, a cute baby. Any questions? I will also just be up here for a couple minutes after the presentation in case you have anything else. Yes, sir.
Are Lego bricks considered sharp?
I would not consider Lego bricks to be sharp. Right. The crux there is that there's not a lot of pressure such as you would step on them. That requires your whole body's weight before it starts causing you problems. And generally, the pressure of peristalsis is not going to be enough to make that a sharp object.
And all Lego bricks, they are not radius.
They are
radius.
No, I don't have. I believe that they can see them, but they are not densely radiopaque. I've seen some in my time that have some. You can see where they are, but I would consider them as if they were radiolucent if you can't see them on the X-rays. Another thing that I was asked another time. There are some of these magnetic blocks that they have nowadays, where you can use them as a construction kit, but If you find that one's been broken open, of course, try and identify all the magnets. If you find that there's more than one missing, or you suspect that the child is seeing one, then of course getting the X-ray would be important. In general, if you just do one, they're probably going to pass through just fine, but there's one same risk of perforation. Yes, sir. We think it's a combination of poor gastric emptying as well as the pH and bacterial changes that are different in premature babies versus mature babies. Yes, mostly the proteins, the whey and casein form that conclusion. Thank you very much.